and it's no radiation. So if you can't see it midline, you come coronal, and you do it this way. And it's the left coronal, not the right coronal, because what am I going to see if I come from this side?
IVC.
I'm going to see IVC first. I'm going to see aorta first. So I go to the right side, the left side. Okay? If they look for the IVC, because part of the protocol on a leg is if you have a positive DVT, you go and you look at the IVC. Okay, because the IVC, the blood clots travel from the leg up the IVC into the heart or the lungs. Then you have a pulmonary embolism if it's in the lungs, or you have a heart attack if it lands. It could go into your brain, and then you die from that. You have a stroke. Breast. Okay, there's no preparation for breast. Okay, the only thing that we ask of them is they are very definitive about where the mass is. You either give them a pencil and say, with the tip of this pencil, tell me where it hurts. Okay? With a marker, you're going to put a mark, a ballpoint pen or magic marker or a skin marker in that area. Okay? And or you say, with this pencil or with your finger, point to where it is. Now, we only do the area that the patient either tells us to do or where the mammogram tells us to go. Ultrasound for mammography is not a screening exam. Okay? This is as far as I can see. Okay? That's as wide as I can see. This is as wide as I can see. Okay, depending upon the transducer you use, how easy do you think it would be to miss a mass if I'm only looking at something this wide? A lot. Okay? So that's why we only go to the area that the radiologist tells us to go or where the mammography report tells us to go. If the patient goes, but I'm really hurting over here too. I'm really hurting over here too. Yeah, sometimes I'll look over there, but I don't take any pictures of it. Because it makes them feel better. Does that make sense? If I find something, I have to document it.
Right.
And do you think I'm going to get held whenever I go to the radiologist office? Absolutely yes.
Oh, because you went that way.
Yeah.
Instead of sticking to where.
Because I was only supposed to be at 3 o'clock on the left breast, not at 9 o'clock on the left breast. And he's going to say, why did you do that? Well, the patient pointed to that area. It says on the film, patient point of interest. Okay? In other words, I covered my rear end by putting patient point, and they abbreviate that POI. Patient POI.
Oh, that patient was PT.
Yeah, PT. But PT POI. In other words, the radiologist said to go over here, but the patient said to go over here. If I would have just put 3 o'clock left, right breast, I'm going to get in trouble. But if I put the patient told me to go there, then I can do that. But if I don't see anything, I'm not going to take any pictures. Because the more pictures I take, the more responsible the radiologist has to be. But if I see something, I'm going to document it. Does that make sense? Okay. There's 2 ways to do the breast. Okay, so now this is my breast. Here's my nipple. This is my areola. Okay? 12, 3, 6, 9. Okay? Right upper quadrant, left
Upper quadrant.
upper quadrant.
Oh, it's like the,
Left inner upper quadrant. Okay? Left lower inner quadrant. Left lower
Right.
outer quadrant. Okay? If I were to do that, sagittal and transverse
for each quadrant.
for each quadrant. Okay? But they also do radial and anti-radial. Always towards the nipple. Radial, 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 radial. Anti-radial, 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 anti-radial.
Ms. Shepherd, I just want to confirm, if you're doing, let's say, the left breast, it's still right upper, right lower,
Yes.
left upper, left lower.
It doesn't matter if this is left or right. It's still gonna be 12, 3, 6, and 9. Okay, but this is the inside of this breast. This is the inside of this breast.
No, as far as quadrants are concerned,
They're
they're
still
right
the
and
same.
left. Okay.
They're still the same. Okay, so there's radial and anti-radial. Now, how they come to us is called BIRADS. Like, they'll have a mammogram. Hardly anybody ever comes just for an ultrasound because ultrasound is not a screening exam. So they come to us and they're a BIRAD 0. Okay, we're going to teach you about the BIRADs. But a 1 is normal. A 0, and I'm just making these up. A 0 could be, I see something, but it looks abnormal. 6-month follow-up. A 2. I see something, it looks suspicious, let's come in for additional imaging. BIRAD 4. Ooh, it looks pretty suspicious, let's do a biopsy on it. Okay. 5. Ooh, that looks really bad. Let's just go ahead and take that out. Okay? And we're going to teach you what those BIRADs are. Okay? And the sonographic features that go along with each one of those BIRADs. That's what BIRADs mean. Okay? Elastography. Elastography tells us, it puts the breast in different colors. Dense tissue is one color and fat tissue is another color. So if I have an older woman that is mostly like for me, I mostly probably have fatty breast, okay, because I'm 65. So my breasts no longer are able to make milk because I don't have the hormones to activate the breast to work. And so they get kind of droopy and they get kind of spongy feeling. Well, that's called a fatty breast. Well, a fatty breast is gonna have a different color in elastography than if I were to do one of your breasts. It's gonna be firmer, it's gonna be youthful, it's gonna be nice and firm. So the colors would be different on elastography. But if I have, say I have a fatty breast, but then I've got a hot spot where it's really, really red inside that fatty breast, then they know I've got a mass there. Because the mass is gonna be, it's not as elastic as the tissue around it. That's how it gets its name, elastography. Okay? Now, ultrasound is very, very operator dependent. Sometimes the radiologists are 100% dependent upon your knowledge and your scanning skills. Don't be one of those overconfident sonographers that knows it all. Because you're going to run into problems and you're going to have a really short career.
No, we don't.
Because it's a really small community and word spreads fast from hospital to hospital. Okay? So if you work at a clinic and say you missed 5 pathologies in a month, they give you your pink slip, it's before your 90 days, you just go find another job.
I got it already.
They're already gonna know. Cause it's, when you think I'm lying to you, it's a really small community. And we know everybody. Okay?
Even in Katy?
Yep. Most of Katy has our sonographers there.
Oh.
Mhm. I know I have three of my previous students work there. Okay? Okay.
You think it was still fun?
We have sonographers in every hospital that I know of in Harris County, including Lake Jackson, Galveston. Okay? It's a really small community. Okay, so say you're one of those types of people that you just can't get to work on. Well, I have to let you go. You've had 52 lates in, in a year, you've had 52 lates. Yeah, I've overlooked you, but finally management got on to me because I'm not getting on to you and I have to let you go. You don't think your next employer is gonna know that? You'll be sadly mistaken if they don't. Because they're gonna know it. Okay. Oh, scrotal exams. I love small parts. To me, small parts are the most challenging. I love using my brain. Small parts are breast, thyroid, and scrotum. Those are the ones that you're going to have to combo. There's 4 of them. Breast, thyroid, scrotum, prostate. Okay, because we put prostate under small parts, but only because it's sagittal and transverse. Okay, there's no patient preparation. But we have to maneuver the testicles so they're immobile. Okay? We're gonna teach you how to immobilize them. Our way is not the only way, but you're gonna observe that in the clinical setting. Okay, you're gonna observe that. We can only tell you how I do it different than Mr. Norsworthy. Mr. Norsworthy probably does it different than Miss Patel, even though they both went to the same school. They picked up habits that they like better than the way that I taught them. And that's completely okay. But you have to do the protocol. Okay, you have to do the protocol. Not only are you looking at the testicle, but you're also looking at the epididymis. The epididymis, you're going to be learning about that there's a head, body, and tail of the epididymis. And it's always lateral to the epididymis, to the testicle. So if you show me, and they're slippery little devils, they can lay in there any way you think. Some of them lay in there sideways and upside down. Okay, just know that the epididymis is lateral. Okay, and that way you won't get yourself confused. Okay, not only are we looking and comparing the size and the echo texture, but we're also looking at the different color. Are they both homogeneous? Is one homogeneous and the other one is heterogeneous? Does one have speckles in it, or do they both have speckles in it? Is one hyperemic, meaning more color than the other one? then I've got some type of an infection in there. Because they should both be the same, okay? And we're gonna teach you the protocol. It's the exact same protocol as a kidney, except you're adding the epididymis. It's just transverse, medial, mid, lateral.
And that will be learning.
You'll be learning it